So welcome to Virtual Grand Rounds. My name is Rachel Bockol, and I'm a second-year medical student at Geisinger Commonwealth School of Medicine in Pennsylvania, and this year's American Academy of Developmental Medicine and Dentistry Virtual Grand Rounds Chair. So for those that are new, Virtual Grand Rounds are a webinar-based presentation model that creates a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round sessions is to expand and strengthen the IDD healthcare workforce across a spectrum of experience levels. And we also have a COVID information page, so please visit that for any information on COVID-19. In addition, if you have any questions throughout the presentation, you can write them in the Q&A box should be down below on your bar down there. So we will go over as many as we can at the end, and please make sure to send them in the Q&A box. So if we don't get to any of your questions, we will post them on the website afterwards. So without further ado, I will introduce our speakers for tonight. We have Dr. Swanson, Stephen Foreman, Dr. Kristen Compton, and Dr. Matt Holder. So first, Dr. Swanson. Dr. Swanson graduated from the University of Illinois College of Medicine. He completed his residency and child psychiatry fellowship at the University of Cincinnati Medical Center and is board certified in adult, adolescent, and child psychiatry. He has 30 years experience treating children and adults on inpatient and outpatient settings. He is the medical director at Lee Specialty Clinic and has been with the clinic since 2016. We have Stephen Foreman, who brings more than 15 years of experience providing behavior analytics services and management of both clinical and non-clinical staff. Stephen began his career in Florida, working as a practitioner specializing in providing behavior supports to individuals in residential and family settings with intense physical aggression and self-interest behaviors. Mr. Foreman then moved to Kentucky in 2009, where he had the opportunity to grow and direct one of the largest behavioral support companies in the state, providing behavioral programming and crisis services to hundreds of children and adults. Throughout his career, he has worked in many settings, including schools, state institutions, community homes, and clinics. He has also had the privilege to supervise students and other behavioral analysts across multiple states and enjoyed watching their clinical skills blossom. Since 2014, he has worked as the chief behavior analyst of the Lee Specialty Clinic in Louisville, an interdisciplinary medical clinic working with adults with severe challenging behaviors. Stephen received his board certification as a behavior analyst in 2007 and his Kentucky ABA license in 2011. Stephen is a founding member and past president of the Kentucky Association for Behavior Analysis, past vice chair of the Applied Behavior Analysis Licensing Board, and a Kentucky clinical director for Special Olympics International's Strong Minds program. Next, we have Dr. Kristen Compton. Dr. Kristen Compton is a 2003 resident of Alice Lloyd College and a 2007 resident of the University of Louisville School of Dentistry. Following dental school, she furthered her education by completing a fellowship in developmental dentistry, a program exclusively focused on adults with intellectual and developmental disabilities. Throughout her career, Dr. Compton has held director-level positions at the prestigious Orange Grove Center in Chattanooga, Tennessee, and is currently the dental director at the internationally recognized Lee Specialty Clinic. Dr. Compton's passions for persons with IDD has inspired her to obtain both clinical and didactic teaching positions with the University of Louisville School of Dentistry, as well as being the clinical director for Kentucky AEGD program through NYU Langone. Additionally, she is pursuing a master's in healthcare administration to promote health equity and eliminate access to care issues for those with IDD. Finally, we have Dr. Matt Holder. Dr. Matt Holder, as an international leader in the emerging field of developmental medicine, has advocated on behalf of people with intellectual and developmental disabilities for better quality services, health services. Dr. Holder currently serves as the Global Medical Advisor and Chairman of the Medical Advisory Committee for Special Olympics International. He is a co-founder and past president emeritus of the American Academy of Developmental Medicine and Dentistry, president of the American Board of Developmental Medicine, and is the chief executive officer of the Lee Specialty Clinic in Louisville, Kentucky, an interdisciplinary teaching and research clinic whose mission is to address the health needs of patients with IDD. As a physician, educator, and healthcare advocate, Dr. Holder has impacted the state of healthcare policy, research, and medical education around the world. So I'm so honored to have our very accomplished speakers present tonight. So thank you for joining us. So you should have screen sharing capabilities and feel free to get started.
Let me just take this opportunity to welcome everyone to this virtual grand round. My name is Alan Wong. I'm the president of the American Academy of Developmental Medicine and Dentistry. As our organization title implies, we are a collaborative group of physicians, dentists, healthcare providers working diligently to improve advocacy, education, and access to care for all our friends with IDD. Tonight, we have an interdisciplinary webinar series for clinicians to learn from colleagues in a patient-centered manner with the purpose of encouraging comprehensive care provision to patients with IDD, especially during this COVID-19 pandemic. We are fortunate to have the Elite Specialty Group with us tonight from Louisville to share their model. So my personal welcome to Dr. Swanson, Compton, Holder, and Mr. Foreman. Thank you to our student resident VGR committee and Dr. Rachel Bockol, our host, and Dr. Michelle Cornaccio, our faculty advisor. And behind the scenes, thanks to Courtney Frey and John Hood for setting up and running the program. And this is partly co-sponsored by Indiana University, Purdue University in Indianapolis. Thank you very much. Dr. Holder.
All right, thank you, everyone. Just before we get started, I do want to give another shout out to Indiana University School of Dentistry. They approached us and kind of came up with the idea of doing this. Also want to thank all of our great students from our student chapters for continuing the virtual grand rounds that we've been doing for a long time. It's good. It's actually my first one doing one. I've watched many. What we're going to do tonight is talk about interdisciplinary care. For those of you who have watched the VGR series before, I think it's important just for us to note that really we're shooting for the student level at this for this virtual grand round. So for any of you who might be very seasoned in the area, the first part might be a little bit basic, but I think you'll find certainly the case and the discussion worthwhile. So the Lee Specialty Clinic is where we all work. We're in Louisville, Kentucky. The Lee Specialty Clinic is a interdisciplinary patient care teaching and research program. We serve exclusively patients with intellectual and developmental disabilities. Mostly we focus on adults. However, we do take some children, typically ages 13 and older. If you want to learn more about the clinic, I've got the web address there up on the screen, leespecialtyclinic.com. And as always, we like to thank the Commonwealth of Kentucky, the Center for Medicaid and Medicare Services, the Cabinet for Health and Family Services in the Commonwealth of Kentucky, and the Department of Behavioral Health and Developmental and Intellectual Disabilities, because they provide us with the funding for this clinic and the wonderful things that we're able to do. So moving along, I want to tell you about first our core services. This is what we provide at the clinic. Basically, we provide primary care, medical care, primary dental care, psychiatric services, behavioral services, therapeutic services, PTOT and speech, crisis intervention. And then we also have an entire set of specialty services that we provide. I'll just read the list: neurology, ophthalmology, endocrinology, podiatry, physiatry, gynecology, audiology, nutrition, periodontics, prosthodontics, oral path, and oral surgery. So we do a lot of things. We can actually bring on a number of other specialties as we need to. And the important thing is that we're not all working in isolation in our own bubble. We are all working together really as a team to try to provide the best care that we possibly can to patients. It's one of the nice things about being in the environment that we're in is that we're afforded that opportunity to really work together. Now, we are very unique. We are one of actually 3 clinics in the state that serve people with IDD. I believe that we are the largest, and you can see this is an outline of the state of Kentucky. And the red areas here are the counties that we pull from. And just to give you an idea of how far some of our patients come, it is not uncommon for our patients to drive or be transported 3-4 hours each direction to get to our clinic. And I think that's important to note because it doesn't necessarily reflect how good of a clinic we are, although I think we're a great clinic, but I always like to make the point that they're passing a lot of dentists and a lot of physicians along the way to get to us. And for one reason or another, they're not able to make that connection with those providers. And so part of our mission is to help change that. Just to give you an idea of what our patients look like, I'm just going to look at one dimension, and that is intellectual disability and sort of the standard classification of intellectual disability: mild, moderate, severe, and profound. If you look at the general population, what you would expect to see is about 85% of people falling with intellectual disability falling in that mild category, about another 10% falling in that moderate category, and about another 5% falling in that severe and profound category. At the clinic, at least specialty clinic, we see quite a different mix, and it's almost exactly broken up into thirds between severe, profound, moderate, and mild. And if you think about it, it kind of makes sense because these are the individuals who are falling through the cracks of the healthcare system, and that's really what we're there to do, is to make sure that people don't fall through the cracks. One thing I think is important to point out is that as you go down that spectrum, mild, moderate, severe, profound, because we're talking about neurodevelopmental disorders, and the complexity and the severity of those kind of go hand in hand. And so when the same mechanisms that cause intellectual stability also tend to cause things like seizure, things like autism and neuromotor dysfunction, psychiatric issues. So what we tend to see is all of those things increasing over time, increasing as the intellectual disability is more severe. And not only do we see it being more common in people who have more significant intellectual disability, but we see those features being more severe themselves. So the complexity really tends to increase exponentially as you get into the more moderate, severe, and profound range. Just a quick shout out to Lauren Clark, who did the research at the Lee Specialty Clinic to give us this graph, by the way. One of the most important things that we see and that I like to talk about is the concept of diagnostic overshadowing. When it comes to people with intellectual and developmental disabilities, this is the #1 problem, I think, that we see. And diagnostic overshadowing is basically a fancy word for misdiagnosis. It's being led in the wrong direction, essentially. So just a couple of examples of what that might look like. Somebody who has been admitted to an inpatient psychiatric facility due to their autism. In one case of our patients, it was because of a hiatal hernia. You can see some of the other examples, but typically the way that this works is there will be a behavior complaint of some kind that will be picked up by a caregiver, who will then go to most often a primary care physician, who will hear the behavior complaint. But if they don't know anything about intellectual stabilities, what they're going to immediately hone in on is that behavior complaint, and they're going to want to medicate that behavior. Once you medicate a behavior, behaviors go away. Whether you're really treating the right thing or not, typically they go away. And unfortunately, a lot of times it's not really truly a psychiatric issue, it's something else. The problem actually will get worse over time, and the behavior starts to increase again. And then we're right back where we started. And sometimes this cycle can go on and on and on, and it can lead to a lot of polypharmacy. It also leads to a lot of delay in care, and it leads to a lot of escalation of simple medical issues or dental issues that then turn into very complex and very problematic ones. So at this point, I would like to turn it over to my colleague, Dr. Swanson, to take over.
Thank you.
Dr. Swanson.
Hello, everyone. To follow up on Dr. Holder, one of the things we're trying to convey tonight, there's two, I think two major themes. One that you're going to keep hearing is interdisciplinary. And the other is in the next couple of slides, I want to give you an idea of how we think differently. Since my thinking continues to evolve, and it has certainly changed a lot since coming to the clinic. But for psychiatry, referrals drive a huge percentage of referrals to the clinic. And it's most commonly for behaviors, acting out, aggression. Aggression is by far and away the number one complaint, and frequently the reason people come to see us. For caregivers and for other providers in the community, aggression is the problem, and something needs to be done about it. However, when you deal with our population in a multidisciplinary way, we view aggression as a form of communication. What is the patient trying to tell us when they're acting out? And that's actually kind of our starting point. What is the problem? Aggression is seen by others as the problem, but what is the problem behind aggression? Next slide. So when aggression is viewed as a form of communication, your entire outlook and treatment philosophy changes. It sounds like kind of a weird thing, but to think of, but what are the benefits of aggression for a person with intellectual disabilities who probably has limited verbal skills and other outlets that a lot of us have? Adaptive benefits of aggression: exerting control in the environment, getting someone to stop doing something that has a reward for the patient, avoidance, feeling powerful, an expression of emotional discomfort. Sometimes it's sorrow and pain, or an expression of physical discomfort, pain, dental pain, constipation, infections. Three common drivers that bring patients to me for psychiatry, those three things. So I just want, this is a study from 1997, but physical illnesses are often missed in our patients, physical and dental. There's a study done 1997, 75% of persons with intellectual disabilities referred for a psychiatric assessment had untreated or undiagnosed medical conditions. 45% of them received non-psychiatric medications that could produce psychiatric symptoms. Next slide. So again, the way you think and interdisciplinary care. When diagnosing persons without IDD, the typical psychiatrist, in a lot of my practice before I came to Lee Clinic, was relying on the patient reports, and even if most of you are familiar with the DSM-5, that is really relies on patient reporting of symptoms. Well, our patients aren't able to do that with words and good, thorough communication. So not only does the task at hand necessitate looking at the patient differently, but finding the underlying cause can't be done by a psychiatrist alone. We really emphasize a team approach. The interdisciplinary team should include thorough exams by internal medicine, dentistry. We have other staff we work with: neurology, psychology, gynecology, speech therapy, audiology, behavior analysts, occupational therapists, and physical therapists. I hope many of you can visit our clinic someday, and what you'll see is a very fluid and dynamic atmosphere. It's not uncommon for Dr. Compton to come in my office and ask about a patient, or ask me to come down to the dental clinic and see a patient. I often have Steve Foreman in appointments with me, speech therapist, OT. I go in the OT appointments a lot of times, and not only is it a lot of fun, but I learn a lot from the different viewpoints and vantage points.
So this is usually the part of the presentation that I ask who's heard of a behavior analyst or how many are in the audience. You don't have to respond in the chat. Usually I get a lot of lookaways, but really quick, I just want to go over what is a behavior analyst and who am I. We conduct descriptive systematic assessments. We design behavior-like interventions. Everything we do in regard to the assessment piece is geared towards individualized treatment plans. The most important person in that is the patient themselves. So when it comes to sitting down and doing an interview or an observation, it is about the patient, and it's about making sure that we get their input in addition to the caregiver, but it's their input that is really important to effectively develop not only treatment, but to choose the correct assessment. One of the other things that we do is to make sure to provide the input and the consultation to others. At the Lee Clinic, one of my, the Lee Clinic, when I'm there, I'm probably the only one running around in tennis shoes because I go and I work in every department. As Dr. Swanson mentioned, we all come in and out of every office, but I provide ongoing trainings, individual trainings, quarterly trainings on behavior skills, basic behavior principles, everything that we can utilize within our practice to be able to make sure that not only does the appointment go really well, but that at the end of the day, the caregivers and the patient leave with some sort of skills that they might not have had prior to coming in. So of course, as a behavior analyst, I ascribe to applied behavior analysis, which is a scientific approach to the behaviors. The elevator speech on this is we examine functional relationships. We try to demonstrate the cause relation between the environment and the behavior. Environment, behavior. We look to see what we can help with manipulating and inserting into the environment that could be helpful for, again, the patient, the caregiver. The emphasis on the environment causing the behavior is because the environment's all around us. The environment has the effect positive reinforcement increases our behavior. And so it's trying to find that right motivation for that. We avoid the hypothetical constructs, which means that we don't guess. It's about, again, that true assessment. And we'll go over that a little bit later as we move on. As Dr. Swanson mentioned, behaviors, they serve behaviors can be self-injurious behavior. It can be moving your hands in the environment. It can be aggression. They serve a communication intent. There's a function to what we do. And we're directly related to the environment. When we look at it, we know that one behavior can serve multiple functions. Serve a function whether going into dental clinic, and someone wants to not be there, so there might be some self-injury, as compared to going to physical therapy where they enjoy it, and the self-injury might serve as something that can be automatically reinforced. So again, we want to make sure that we're looking at everything, and our goal always is prevention when it comes to looking at these behaviors. I am so lucky to have a great team of talented clinicians and staff that help include in the assessment piece, help include in the treatment piece. Without the team, without the patient, without the caregiver, without the history that we get, without a lot of the documents we collect, trying to understand behavior, some people is like smelling the color 9. It can be very complex, and without appropriate assessment and intervention, we don't really get anywhere. And so we're lucky to be able to have that, and to be able to work with great folks like Dr. Compton, who's going to talk a little bit about what she does in the dental clinic.
Okay, so I think we can all agree that, especially my dental friends, that we see high levels of dental disease in this population. However, what makes what we do at Lee Specialty Clinic different is our holistic treatment planning. That's what really sets us apart. So when we do a holistic treatment plan, it requires the dentist to consider factors other than just the dentition. So we want to think about things like if we're treatment planning a fixed bridge, then we may need to consider, does that patient's spasticity, could that be something that could possibly break that bridge, or something that would, fracture the porcelain? We have to think about things like uncontrolled seizures in our patients when we're doing treatment planning for patients. Those are all going to be things that are going to build on the success of not only the dental treatment itself, but also the patient's overall health. So what do we do exactly as far as services in our clinic? We do the full gamut of general dentistry, everything from prevention, basic restorative. We do full endo, including molar endo, which is root canals. And then we do have some dental specialists, as Dr. Holder mentioned, that come in and work with us as well. We have an oral surgeon, and we also have an oral pathologist. But perhaps one of the most important things that we do in the dental wing is teaching. So passing on our knowledge is absolutely critical to improving access to care for this population. And so in the dental wing, we do have a very extensive teaching program. We have a CODA approved AEGD residency program. That program is through NYU Langone. It's a 1-year program. We also have a year-long fellowship program for both dentists and dental hygienists. And we do also offer a mini residency, which is often an option that dentists or dental hygienists who have been out of school for a while, but maybe they're interested in just coming in and getting a condensed version, an immersion into what we do. We do offer a 2-week mini residency, and that is actually open to dentists across the entire globe. So let's look at what it looks like to become a patient of an interdisciplinary care clinic. So in our clinic, just like every other clinic, a patient fills out a new patient packet. But what makes our intake process very different is we look at gathering as much data as possible, including things like their neurodevelopmental diagnosis, any behavioral or sensory concerns that may impact how we treat that patient or how we may set up their room. And we ensure we can properly communicate with our patients. So we always want to know, does our patient need a translator? Do they have a communication device? We want to make sure they bring those things with them to their appointment so we can communicate with our patients. We also want to work with the family and the patient to ensure that we have proper informed consent prior to starting any treatment. So this may require us to screen a patient for decisional capacity, or it may require us to obtain guardianship documentation so that we know exactly who we need to be obtaining consent from.
And when it comes to the assessment piece, so we have, of course, as Dr. Compton mentioned, we have our initial intake packet, but it goes beyond that. When we see a patient, we do a thorough documentation review and communicate with the caregiver and any other provider. We have individual patients that come in from all over, and they might have, say, a community behavior analyst they work with, or they might have a one-on-one worker, go to a day program, et cetera. So we want to make sure that we're doing our best to get documentation and communication. Sometimes we ask for data, and I'll get 6 inches of data sheets sent, and I love it. So we want to do everything we can to review the documents. Assessment doesn't stop for us. Again, it begins in the lobby. It begins with greeting. Our receptionists are trained on interactions. They're trained on what questions to ask. When I go to sit down with someone in the lobby, especially a new patient, I sit with the patient and I say, what do you like? What do you like to do? What are you doing after this appointment? Just again, building that rapport that is vitally important. As Dr. Holder mentioned, we see a lot of folks that get turned down from care, and it's primarily due to their behavior challenges, their aggression, or the appearance of their behavior challenges. We don't have to go into all that. What that means is we get someone in and we get him through an appointment, and they say, wow, we've never been able to have this successful lab draw, or have a successful full medical assessment, or to sit with our psychiatrist for an hour. What is it about the Lee Specialty Clinic? And it's the people, and it's the folks that are in there that are really digging into the assessment and really knowing the patient, interacting with them is, again, I'll say it 100 times, that's the most important person that we're there. And then at the end of the appointment, we're still assessing, we're still giving guidance to the patient, the caregiver, the parent, whoever is there with a post-appointment. We don't just hand them a piece of paper and say, see you in a month. We make a plan for what's going to happen next. And I can speak for everyone in the clinic. No one leaves without how to get in touch with their provider, email, phone numbers, whatever it is, to make sure that they always have the ability to access us. Again, we're there for them.
So we do encourage all of our patients to take advantage of our 3 main departments, which would be medicine, dentistry, and then the psychiatry and behavioral health piece. Even though we don't require that, we do encourage it because we are an interdisciplinary care clinic, because we are able to speak to each other, because we are able to do what we call curbside consults, where we can just walk down the hall and talk to one another about a patient. It really makes the care that we're able to provide better for our patients. Once we do those initial referral evaluations, then we may make referrals to other departments as needed.
So now we're going to present a patient. She is a real live patient. She's been in the clinic recently. Her family's given permission for us to discuss her, and she's a fairly average patient at Lee Clinic. But Jane is a 59-year-old white female with a history of severe intellectual disability. She initially presented to the clinic in September of 2016 to establish care, and she was brought there by her sister, who said that she didn't have a doctor in the area. Basically, she lives about an hour away from the clinic and had been turned down by all the doctors in her area. She's very sweet, but she's very hyper, and she's giddy and noticeable. In terms of some of her workup, just to give you some ideas about the things we look at, we always try to establish a neurodevelopmental diagnosis. In her case, her chromosome analysis and her microarray were negative. We screen everyone for Fragile X syndrome. That was negative as well. Her developmental mother reported a normal pregnancy and delivery, and said that milestones were normal. Now, this is per the sister who brought. Mom is now 93, except she didn't speak until after the age of 2. She was raised in a sequestered home environment with her parents. Was described as happy-go-lucky, and her sister said she was spoiled, meaning her parents indulged her a lot, and when it came to making demands and Jane put up a fit, they backed off very often. Family history in terms of do conditions run in families and so forth is noteworthy. All we know is that she had a 22-year-old sister with an unknown developmental disability who died when Jane was a teen. In terms of her first appointment, sometimes the first appointment is with psychiatry, sometimes it's with dental, sometimes it's with medicine. In this case, she saw our colleague, Dr. Robinson, in September of 2016. And the primary complaints at that time were actually mood swings, depression, and behavior change. And her 91-year-old father had fallen 2 months prior and was confined to a nursing home. And when Jane would go visit him, his condition, his weakness, and the medical environment and equipment freaked her out. And she became extremely anxious, started picking her skin, started becoming increasingly difficult to manage. In terms of her medical history, she has a history of a heart murmur. She had a history of elevated pneumonia, and that is resolved. We never figured out what that was about, and vitamin D deficiency. She only takes liquid medications. Her mother always had a fear that she would choke, and when capsules or pills are ordered, she would chew them up, sometimes spit them out. Sometimes mother would just simply say, you don't have to take them. As is typical of a lot of our folks, she has a suspicious lesion on her chin. She had multiple visits to a dermatologist who wanted to biopsy it. They tried several times in the office. They would only do it under general anesthesia, and the sister refused that, so that was not worked up. In terms of her initial presentation to Dr. Robinson, she was hyperactive, anxious, didn't want to be there. She only speaks a few words or phrases, said, I don't want, no touch, and scared. She initially wouldn't allow to have her blood pressure and vital signs taken, refused a physical exam. As is typical, are not unusual, and the advantage of a clinic like ours. She was attempted to run off and so forth. Dr. Robinson enlisted Steve and our occupational therapist, Sarah, to desensitize the patient. So they took her in the hallway, played with some large balls, got her laughing, got her enjoying, got her comfortable with the clinic. And although she wasn't completely cooperative with a full medical exam, Dr. Robinson did do a cursory exam, and we did get vitals. And very importantly, thinking of the long game with patients and wanting them to feel welcome about coming back or feel comfortable, she left the clinic in a good mood. She was then followed up with an appointment the following month by my colleague, Dr. Goldstein, for psychiatry. And it just so happens that her father had died the month before. Actually, he had died like 11 days before. And she was diagnosed with, she was acting out a great deal, a lot of anxiety, but the diagnosis was bereavement, and no medications were prescribed, except for she was given a prescription for Ativan as needed prior to dental appointments or medical appointments if she was too anxious to come.
So let's look a little bit about how we treated this patient in the pre-COVID world. So once we got her comfortable with coming into the clinic, she did have annual medical and psychiatric appointments, and then other appointments with those departments as needed. Dentally speaking, she had a history of dental work with general anesthesia only prior to coming to our clinic. So we did do a lot of work, again, utilizing our BCBA Stephen to determine any types of necessary behavioral interventions. One thing that we did learn was that she really enjoyed deep touch pressure. So we used a weighted blanket with her and she really enjoyed that. We also do have some sensory balls and things like that in the dental clinic. So similar to some of the therapies that were done with our occupational therapist, again, trying to carry all of that over. You can see here she did have active caries. She had some severe attrition. She had pulp exposures. So she was in desperate need of dental care when she came to us. We saw her approximately every 30 days until she was caries free, and then she was placed on a 3-month recall.
And as timid as timid and shy as she was in the first appointment, as Dr. Swanson mentioned, through working with her and sitting with her, we found that she enjoyed playing lots of games. She enjoyed playing chase. She enjoyed, ready, set, go, and taking off. And so we stopped having an issue of waiting room to treatment room, wherever that was, because she knew that when she coming in, she's going to race somebody. And she is very fast and won every time I raced her, that's for sure. But she enjoyed that interaction. And, she was going to a therapy appointment or medical appointment, also got to assess gait and things like that. But she learned to have a really good time as best she can while coming to the clinic. So she enjoyed the frequent visits that she had, which allowed any of the anxiety-like behaviors, the skin picking or bolting to practically disappear.
So I saw her in psychiatry for the first time in March of this year, and it was the middle of March, and it was the onset of COVID, but actually she had had several months of acting out prior to the pandemic. A series of things acting out happened. She showed a lot more anxiety. She was refusing to get on the transport bus to the day treatment program. Her mother, who's now 93, had become increasingly elderly and debilitated, and Jane had pushed her down at times. And mother is also reported to be forgetful. But she also started having crying spells. And her sister who brought her, there was no obvious precipitant, but they were occurring more and more frequently over the weeks before I saw her. Sister noted that she did much better after a good night's sleep. And she didn't look as robust as she did normally. So there was a presumptive diagnosis of depression. So I prescribed an antidepressant medication called Remeron, which many of you may have heard of. It's often used by some doctors as just simply a sleep medicine, but it is an antidepressant. Go ahead. I saw her back in July, and she was doing a little better. The pandemic, as you saw in the prior slide, her day treatment was closed. She was not getting out and walking as much as she had. She was having some struggles, but she wasn't crying. She was getting sleep most of the nights when mother would be able to give her the medicine. That was 4 to 5 nights a week. And she was doing okay. In October, I saw her again, and she had had a serious decline in the prior month. She had been seen in dental for an urgent appointment and diagnosed with a dental abscess. But it was unclear. She had basically regressed a lot, as have all of our patients during the pandemic. And just as an aside, we're all a little isolated more during the pandemic, but our folks with intellectual disabilities are really shut down and closed in, and very often they don't leave the home for anything at all. Again, mother getting increasingly ill or infirmed, and the dental abscess, as well as the medication only being given on a part-time basis. I did increase the dose of the medicine, thinking we'd get more in her on the days that she received it. You can go ahead.
So as Dr. Swanson mentioned, she did have an increase in her behaviors again in September. We did schedule her for an urgent dental appointment in September, just as another, again, trying to evaluate the patient from all angles to see if there was something else going on. She exhibited many of the same behaviors that she did in her very first visits to the clinic, which we have already discussed. But with the help of Stephen, we were able to get her back into the clinic. We were able to do a brief assessment on her. We were able to get her started on an antibiotic, and then discuss treatment options with the patient, the guardian, and Stephen, so that we could build a plan together. So the patient and the guardian elected to save the tooth. Again, this is tooth number 10. So for my non-dental friends, it's a front tooth. Very important. We want to hang on to those teeth so that our patients have a great smile. And we were actually able to complete the root canal treatment on the patient's very next visit into the clinic. So that's showing us that not only in that second visit, we were able to remove the source of the pain, but the patient was already starting to refamiliarize herself with the clinic and the staff. By the end of the appointment, she was back to playing those racing games that Stephen mentioned earlier. She had a really great time, and she was laughing with our entire team.
Just to go ahead. I just wanted to, sorry to interrupt. I just wanted to throw in, while she was at her follow-up appointment in dentistry in October, I met with Sister in the lobby of the clinic, and that's kind of not unusual about that. The sister reported that she was doing better, that she had settled down considerably.
So one of the things that we learned with her, and we've done this with a few of our patients as well, and continue to do it ongoing, because again, COVID has thrown a wrench into absolutely everything. I'm sure hearing that word on a Zoom, you kind of just, the skin crawls because it's talking about it again. For her, as Dr. Compton mentioned, when she came in that second time, she was more her clinic self. She was smiling. She was able to come back without issue. She would erase us. She was very appreciative, smiling. Even after treatment, it was almost difficult for her to leave. She just wanted to hang out. But so one of the things we're doing with her, and have done, is increase the in-person visits. She since the dentist is seeing our audiologist again, and that appointment went extremely well. And one of the things we decided to do also is to kind of rewind the clock a little bit and re-engage the professionals that worked with her, the OT, myself, and to do the same with other patients, the things that have worked in the past. For her and other patients, increasing the due diligence and the communication to the patient, the caregiver. Again, our goal is prevention. It always is prevention, whether it be preventing behaviors or preventing any sort of medical issues or concerns, to try and get this patient back to a day program, some sort of normalcy in her life. Also looking to increase the system for the behavior change, taking data, providing resources on behavioral health, and just giving strategies for both to be able to use at home and in the community, and have that ongoing. Again, going back to the magic of the clinic, isn't the, you know, are the people in it, and how we provide that care, and how caregivers follow through and they follow up and they send us information. And it's important for us to continue to do that and to get back to how we operate.
I think at this time, you know, this is really concludes the presentation. We can probably open it up for questions. Rachel, I don't know if you want to go ahead and get that going. One of the, I'll just comment that, you know, during the COVID period of time, what we know and what we've seen, just our experience at the clinic in general, has been seeing a lot of patients who, we complain about this all the time, is just falling through the cracks of the regular medical and dental system. The providers that don't know how to work with our patients, and there tends to be some neglect that happens. Let's call it what it is. I call it systemic neglect, and that's kind of what we see, and that's what we fight against. In the COVID era right now, due to factors beyond everybody's control, we're kind of at that situation again. Even in a clinic like ours, where you know, we try to be as patient focused as we can. We pride ourselves on knowing about this population, but we had a situation where you know, this patient wasn't able to come in for a long period of time. Her normal routines that she relied on for prevention probably broke down at home, and you know, she developed this abscess that potentially was preventable, and we found ourselves in a very sort of familiar situation, and I think it just highlighted to us the need and the importance of continuing to focus on that prevention, especially during this time, making sure that we educate our families and caregivers and our patients the best ways possible, and as frequently as possible, to try to prevent all of these things that we usually talk about, but I think in this period are so much more important. So Rachel, I don't know if you want to, if you've got any questions for us, so we'd be glad to take them on.
Yeah, definitely. I can get started on questions. So the first one that I have is, do many of the local community dentists receive training on dental care from this population from LSC? And have you seen these patients now receiving dental care from a local community dentist?
So most of our education, I teach at the dental school locally. So if we have dentists who stay locally in our community who have been to our dental school, then they have had some very specific training on IDD, both didactically and clinically. Other than that, unless a dentist reaches out to us specifically, you know, we don't offer any you know, generalized training in that form. Typically when a dentist calls me, it's because they want to refer the patient.
Okay, great. Yeah, thanks for that answer. So another question we have is, are most of your stable dental patients on Q3M recall, or is that if they're considered more high risk for poor dental health?
So just like everything else, when we treatment plan our patients, everything is very individualized. So we do have a large portion of our patients who are on every 3-month recall. That is for several reasons. As Dr. Holder discussed, we do have a lot more of our specific patient population in the severe to profound range. And so along with that comes several things. The patient may not be able to do their own oral care, so they may rely on someone else. So if they're not getting that oral care from a caregiver at home, then that oral care is going to decrease and increase their risk for caries. If they have behavioral challenges, that may also be an obstacle to oral home care. We have a lot of patients who are on multiple medications, which causes dry mouth or xerostomia. So those patients are also at an increased risk for caries. So in general, we do have more of our patients who are on every 3-month recall than not. But it's not just for one specific reason. It may be multifactorial.
Okay, great. So next question is, how often do patients see specialists and how often do they visit the clinic? And then how many specialists will they typically see on each visit?
So it's a complicated question. When we first opened up the clinic, we probably have on site up to, I don't know, 18 or 20 different specialties, if you will, or disciplines, I guess. And so any of our patients can access all of those services if they want them. The one thing that we felt very important for our clinic is sort of the whole concept of choice and our patients being able to see the providers that they're used to. So if they have a neurologist that they really like, then they don't have to see our neurologist. If they have a psychiatrist they really like, then they don't have to see our psychiatrist. So we really try to work with whatever team they have and sort of fit as necessary. Some patients love the idea of coming in and seeing, or some families love the idea of coming in and seeing multiple specialists at the same time, or one after the other. I guess I'll say that I think our experience has been, for the most part, that while some can do maybe 2 or 3, it's kind of pushing it, but a lot don't really like the full day of poking and prodding, which we've done every once in a while. Somebody comes a long distance and they need, to see, 6 or 7 different disciplines, we can make it happen. So we really just try to take it, one person at a time, one set of needs at a time, and do what's going to work best for the patient.
And I was going to say, there's sometimes where we will co-treat, and primarily co-treat in the sense that we want to get the same history from the patient, the caregiver. So as many providers around to be able to hear that and ask questions is important, especially if we have someone that travels from far away and they're going to see 3 people that day, sit on the same thing 3 times, can get exhausting.
Definitely, yeah. So kind of a question related to COVID. Are you providing telehealth visits during this pandemic? And what types of services are you providing, and what is the patient response to this? And then also, do you encourage dental descents at home prior to dental or medical appointments?
You want to take that one first, Dr. Swanson?
Is that directed toward, I'll just answer for psychiatry. I think that might be a student asking specifically about dental follow-up, but for psychiatry, as always, business is booming, but even more with COVID. And actually, with the pandemic, my personal practice has gone up 50%. I'm beyond booked, and there's 2 reasons for that. I'm in the clinic now only 1 day a week, and working from home 3 days a week. But telehealth has been absolutely wonderful. There's a lot of patients who express missing the clinic and wanting to come back, but a lot of caregivers who are afraid to travel and that sort of thing. The other thing is, it's really for psychiatry. I saw patients today in northern Kentucky, 100 miles from the clinic. I have patients in eastern Kentucky and all of that. It's really good, but it's not the same. And some of the advantages are you can see the person in their home environment, and actually it's more naturalistic in that way, but there's nothing like being in the office with a patient. There's clinicians get a feel for how people are doing after a while, and Zoom doesn't always reflect that. But I think that was probably a dental question.
Well, and I'll say that you also utilize telehealth, and I think the question was in regard to maybe like a desensitization program at home for medical and dental. And the answer to that question is we have patients who I'll be on Zooms with, and we'll work towards desensitization. The tough part with desensitization is when you desensitize somebody, it's something there's already a fear established. So that might not necessarily be the best mode of treatment, And so getting a good history and then bringing them into the clinic really gives me a better picture of what to provide at home, because if you're trying to desensitize at home, but there's not a, there's, you know, the fear is, if there is a fear, you know, the sounds of the clinic, you're not going to work on that at home. And it just, you spin your wheels a little bit. And sometimes without a good program, it's okay for mom and dad to be mom and dad, and let us help them along the way.
Yeah, that's a very good point for sure. So kind of, we have two questions kind of tied together also. Can you speak more on the barriers that many physicians face when treating this population, and what are your perspectives? This is a second question, but what are your perspectives on creating more clinics like this around the country? So first, about the barriers, and some of the specific barriers that were mentioned were price, Medicaid, and insurance.
Yeah, so those barriers are huge barriers. And in fact, I've been involved in a number of different groups and conversations to try to address those. The fact is that our patients are more complicated than other patients. They take more time to deliver good care. If you deliver bad care, then they're going to be more expensive, because you're going to end up with more people going to the operating room, sure, the ICUs, the hospitals. You know, we're trying to make the case right now, and I think it's very important. The number one thing that happens to a person with intellectual disability when they go to the hospital is being put on a ventilator. And that's actually the number 5 thing also, or it's 2 of the top 5, I should say. So, you know, what that tells me is that we are getting to this population way too late in terms of catching things. And when we finally get to them, it's very expensive. And so if we can be preventive and we can show that we're able to save dollars, then hopefully Medicaid, Medicare, which is where who pays for most of the care that we provide, will see the value in providing good care to this patient population. So addressing this is very difficult. It's going to be done on perhaps a national basis, certainly a state-by-state basis. I can tell you that from, you know, again, we're very lucky with the payment structure that we have in Kentucky, because our state really cares about the quality that we provide. They make up the difference that Medicaid and Medicare don't pay, and in order to provide that quality. And I would say that if we didn't have that, we would have to be seeing our patients probably about 5 times as fast as we see them right now. And obviously the quality of that care would go down immensely. So that's pretty difficult.
Definitely, yeah. And kind of touching too on another question. So several people are wondering if there's an initiative to create more clinics like this around the country. What are your thoughts on that?
Nationally, of course, I've been wanting to do that since we opened this one. Actually, since before we opened this one, we kind of described the model back in probably 2003 of this interdisciplinary patient care teaching and research model that would focus on adults primarily and serve as that sort of transition hub for children, you know, aging out. And so the model has been described for a long time. The payment structure is complicated, and it takes some political muscle, you know, some just to get the realization. You know, most of the folks in state government, you know, don't know the ins and outs of this population. So it's up to us, you know, the providers, the families, to be those advocates, to bring attention to the issue. And what we're really trying to focus on now is making sure that we have the financial case as well, because, you know, you'll always find the people that say it's a really good thing that you're doing this. It's really needed, you know, and you know, they're out there with their heart. But you know, somewhere in a back room somewhere, there's somebody counting the dollars. And if you can't make that person happy, you're not going to be able to make this thing fly. So we're working on both of those things.
Great, thank you so much. I know there's a lot of questions we didn't get to tonight, but we can post them on the website after the presentation. And this presentation will also be on our website as well, recorded. So if you ever want to reference it. But thank you so much for joining us. I know you guys are doing very important, busy work, and I appreciate you guys taking the time to present. So thank you so much. And if you guys have anything to add, feel free to as well.
And I just want to give a shout out to the dental students, and I hope the presentation inspired you to take our patients. When you get them, you might fix their psychiatric problems. You might fix their aggression, their acting out, their anxiety and depression by treating an abscess or a cavity.
Absolutely.
Absolutely.
Thank you all. Rachel or John, I don't know, will you all be able to put up our either our contact info or the slide deck if we give that to you? Is that?
Yeah, Def.
Yep.
Okay.
For sure.
All right, great.
And also, I posted the link to where all of these webinars are archived on our website. And I'll put that link one more time because there's a lot of people signing off from where they're from, which is awesome to see people all over the US and Canada. And I didn't notice if other people are coming from around, but I put the link one more time. I'm not sure how long it'll take to get up there, but that will be the place to look for it. And you can also view all of the other past webinars as well. But yeah, we can definitely put any contact information you'd like to share on the website and a copy of the slide deck too. Just send it to Courtney and myself. Yep.
All right. Thank you all. Rachel, thank you so much. Have a good night, everyone.
Thank you so much. Have a great
Take care,
night.
everybody.